What's up, you guys? This is Boy Miguel giving you your daily dose of radiation. In today's video, we'll cover what it's like to take a chest x-ray on the portable machine. So, if you're new to pushing the button, or if you're a student, or if you're just a regular Timmy, a regular person trying to know what it's like, my credentials are I do x-rays and I ER trauma 3 graveyard shift. Where I stand pursuing CAT scan currently. Will be pushing the money there. They make more money. But anyways, so as far as that, the chest x-ray is the bread and butter of radiology, of chest x-rays, of x-ray in general. That gives, I would say, 80% of your job is chest x-ray. So it is very, very important that you know how to do this. Essentially, it's very easy. It just all comes down to several things, which if you go to school, you will learn, and they'll teach you the fundamentals. But in the most simplest form I could put you is, it all comes down to the board placement, and then the tube of your angle, and making sure that it's, like parallel, like it's in the same, you wouldn't want to shoot something that's like I guess like this, and then you're shooting it like this. So you want to make sure it's like this. And that what throws people off, especially the students, is when the patient's like laying like this, but in your mind you're still shooting it like this. So like the picture is gonna get thrown off at a different angle. And I know what you're saying, Miguel. So you tell me, if I place the board correctly and my angle's off, it will throw it off? Yep. Or even vice versa. If your angle's off, if your angle's spot on, but your placement or how the patient is laying is, either forward or all the way back, it will mess everything. Sometimes what I've noticed with certain techs, the placement will be good, but because of whoever's angling it has a different perspective of the machine, of the board, or maybe he can't see the board, so he's just gauging at it. So when he shoots it, the placement can be good, but you're just clipping it. And sometimes the tech who's positioning more, because usually you'll blame the person who places the board first before the beam. So sometimes it is the placement, other times it is the tube. Because you can leave the x-ray board on the same position, but depending how you hit it, it can throw the anatomy in different ways, which is useful, which you'll learn sometimes that's what you need to see certain joints or certain gaps, or to be able to see certain fractures and stuff, so that comes handy. But essentially, you'll grab your 14 by 17 and you'll place it behind the patient's back. Usually it's like a little white line that's like the outskirts of the little outskirts of your, let's imagine this is, the board. So like they'll have a little outskirts on the corner, letting you know, like this is, like from here is, you can take x-rays out here, the little border, it won't. So essentially, you'll place the patient's back, and you'll want this line, which that means there's no portable, you just want it slightly above the shoulders, or quote unquote light above the shoulders. Meaning that if there's light above their, I call it the traps, or above their shoulders, and your board is right there, usually you'll get it. It's a pretty safe range. Now, occasionally you'll have people with high apices, and for the most part, it'll be those skinny, long people that will have their little apices. Usually the apices are just like a little. Sometimes people have the big old like that. You'll see what I mean if you ever Google it. like more peaked, like a hill. Usually most normal people just have like a slight arch, and then there's people who have like a hill. So it's usually skinny folks. And usually the most skinny, anorexic, skinny people have the biggest lungs. I don't know, it's just, I don't know. And you look at it, you're like, damn. So that is more of an advance with X-ray vision type of years. You'll develop that, so you don't have to clip as much. With those patients, sometimes it's recommended that you place it the other way, so it's kind of sideways, to make sure you get it all. But for the most part, chest X-ray is the bread and butter. If you 30 seconds to a minute, depending, all comes down to usually the processing of your machine. This kind of takes a big chunk. If you have a machine that can render out the pictures pretty quickly, you could probably sub 30 seconds. Ours is like 30 seconds because the machine, it just takes a long time to load. So that's, I mean, as far as technique goes, depending on your equipment, it may set like just a generic technique. Ours shoots at 80 kV at 2.5 MA. Oh, less. Which that's standard with that kind of technique. It all kind of depends on your machine, because even if you have two different portables, they will, with the same technique, it would be a different picture. We have like ours, we have two Fujis, Fuji 1 and Fuji 2. Fuji 2, I gotta shoot it hotter compared to Fuji 1 just to get the same picture quality. Which you're like, Miguel, why? So usually it'll come down to the parts you have on the machine. So for instance, when they had to replace the rotor, when they had to replace like certain stuff on your portable, which will give you different results. So for instance, I guess Fuji 2, its parts are more older. So maybe like the filament stuff got worn down, or maybe it's just the way the system processed. I'm not sure. They're like 1 or 2 years apart difference. They look the same, but it's just like, I guess the software, the model, something in there throws it off to where you have to shoot a slightly hotter or a different technique. So that's something with time. Technique will always be something with time. Which I've noticed with ours, because you're looking for the readout, which will spawn in. Ours is a 200 IE is what we use. There's different type of numbers, exposure readouts that you'll know depending on what you're looking for. Ours is 200 is the quote-unquote perfect picture, but usually between 150 all the way to 300 is acceptable. Anything that deviates from there is not unacceptable, but like the image quality will suck. But from what I've noticed, usually if the number is really big on ours, the EIN, it'll be grainy because it's not penetrated enough. And if it's like a lower number, close to like 50 or anything, 100, usually be you shot it hot, so the image is kind of burnt out. And you deal more with burnouts when you're shooting like older patients with their bones maybe not as, dense, osteoporosis. Or if you shoot a kid with an adult technique by accident, it'll burn it out. Yes, so just keep that in mind. As far as what to say, a general rule is, in school you learned about the 120 for chest, and then like 80 for KVP for the belly, abdomen. That's kind of what you learn at school, but that all depends on even between your portables and your actual machines, like the big X-ray machine units, the technique and stuff will vary too on that. So it's all a learning game as far as that. But as long as you have your fundamentals down, you'll just with time, tweak it, and become a better tech. So usually with students or anyone learning, you'll grab the base model that's set, like the standard, whatever generates, and then you'll kind of tweak it from there. For me, for the most part, from what I've seen, the 80 at 2.5 mass, usually with that one, I'll shoot someone who's like an average patient, maybe anyone who's like 120 to 100 pounds ish range, so kind of slightly slim, not anorexic, but just slightly slim. I'll get perfect. Anyone from there all the way to like my size, you may have to bump up like the technique more. Usually they recommend shooting higher KVP, lower mass, because that gives you the lowest dose of radiation. So, over time, and depending who you work with, they'll use different techniques. And something I'll let you know, all the old techs, because it's all because of the type of machines and equipment they had, they shoot it hot. A lot of the times they'll shoot their stuff hot. So what I mean by that is they'll use higher technique, because if you shoot it hot and it spawns in, you're able to correct it and then make it look normal. Because if you under penetrate it and it did not get sufficient penetration, you can't really fix it. But if you shoot it too hot, you can like throw a grid or mess with it and it will compensate for it. Which I don't recommend doing that, because then you're just shooting everyone hot and giving a lot of radiation and then not good. But that's what I've noticed a bunch of the old school people would do. And I've learned that. So keep an eye out for that. So yeah, it's been your boy Miguel. See you on the next one.